Thank you, Martin. If I could have you join, and Sarah and Ines as well, please join me here. We'll enter into our discussion section. Looks like Michael Larson has a question to start us off once you all get settled.
Thank you. My question concerns the last presentation, and for a cross-sectional study, it was okay, very good, congratulations. But prospective studies are great, and it could be that those cases where there is a discrepancy, and OCT-A says no, they have a favorable clinical prognosis, so that they shouldn't be treated. And fluorescein angiography is a reference, but it's not the ultimate truth. Maybe it could be beaten in a prospective analysis by OCT-A. What do you think?
That could be a topic in the future, yeah. I don't think that right now, angiography, I think, is still what we're looking for, what we're looking at, actually, in terms of CNV detection.
But you're suggesting it may be a gilded standard. That's what you're saying, Michael. Okay. Carl.
Yeah, I have another comment about the sensitivity in this study, since I was also a co-author in the study. You have to realize that the segmentation was using the raw segmentation, and when we did the resegmentation, we were moving the lines. With the new software, it's possible to follow the line of the RPE, of the bottom of the RPE, and that self-propagates throughout the case. Now, if you do that correctly, I've been able to show that you can get a much higher sensitivity than what we were showing in this study. So partially, I think it is a question of segmentation, because especially high PEDs tend to have difficulties with the segmentation correctly. So if you do use a manual override, I think that we're going to get a much better result. So I'm actually going to partially go back to some of these patients and see if we can get in these ones that weren't showing up, if we can get a better result if we use the new resegmentation tool.
Also, I would probably like to add that the former talker, she was quite right. There's a difference between treatment-naive detection of CNVs and already treated. So,
Salomon Cohen from Paris. We have to ask ourselves, what is a gold standard? What do we mean by gold standard? In a prospective randomized study, we need probably many tools and fluorescein angiography, of course, is needed to define the presence of choroidal neovascularization. But in our practice, in our routine, it's very different. When you have a patient treated for the right eye for an exudative AMD, and this patient calls you and tells you that he has metamorphopsia and visual loss, probably he has CNV, but we need to document. So what is the minimal documentations we need in our practice? This is the question. That's why we think that it's very important, because we need documentation. We want to be less invasive as possible, okay? And that's why OCT is so important in our practice. Yeah. However, in some cases, it's not sufficient, and we need more. And we think that these two steps, practice corresponds well to the current practice in AMD clinics. But we have to ask ourselves about what we need, what we mean by gold standards.
Right.
And also, we have also other questions. What is a significant PED? There is always a PED in type 1 CNV, but sometimes it's a very shallow PED, a very small one. Is it truly a PED? Or do we need to find a level 250, maybe 300? I don't know which one. But maybe we have to answer to these questions.
I think those are really good points. I think Michael was speaking to the same thing about the gold standard, and it's a challenge because actually one could argue that structural OCT may be the most sensitive for detecting, all of us look at their features, it's just not necessarily specific. Sometimes you can be confused. But prospective trials where you have outcomes may actually ultimately define actually what we need. I think that's going to be the key. Rick, you had a different take.
Sarah and Martin, I thought your talks were great. They had practical significance. Could you tell us why you think the sensitivity was lower in high PEDs. Sarah, you kind of alluded to this, that maybe it's not the RP, but what is it? And when you finally did get to see, in treated patients, you got to see the CNV. Was it in the PED, next to the PED? Did the PED flatten enough so we saw it? Where did you see the CNV?
Thank you, Dr. Spade. Yeah, this is a very important question. And when we saw the neovascularization appear over time after anti-VEGF therapy, it was in all these cases, 50% of the cases that were initially negative, it was beneath the RPE. These were not PEDs with a notch. It was not at the edge of the PED. It was really beneath the RPE. And I'm really intrigued by this observation. I don't think I fully understand it. I think signal attenuation is an explanation, but since the control group was so good, I don't think it's only attenuation from the pigment in the RPE, and that was the purpose of our control group. So I think segmentation is probably also a major issue, but on the other hand, I would have to do this analysis, but before and after anti-VEGF therapy, the height of the PD and the outline of the RPE was not that different. So I think there's something else. Maybe the serous component of the PED. On the B scan, we could see that the lamellar structure of the neovascularization became more visualized over time as well. So,
you know, sometimes we think that the CNV grows up the back surface of the RP. So it wouldn't really matter how much fluid there is, right? If that's the case, because it's right behind the RP, and we should get that on an RP slab. So maybe there's a couple different growth patterns. Some grow up on the back surface of the RP, some grow down on the bottom. Yeah. Maybe it's the ones on the bottom.
And you see that, right? Sometimes you see, like within a PD, you see a bridge of tissue, and then you see fluid above and below, right? Sort of endo and exo sort of fluid pumping sort of patterns. But also, I've been impressed in some of Christine Curcio's images, Hans Grossenklass's. You know, we imagine when we see a PED that we think is vascularized and we see hyperreflective material under the RPE, that there must be vessels throughout that. But sometimes you look histologically, there are vessels only in certain sections of that. And so that's where, like, the segmentation may really matter. I was just curious in your very nice study, Sarah, whether when you did see the CNV materialize later on the OCT-A, did the PED always measure less in height? I mean, because that would tell us something. I mean, there's still an artifact of you've treated it, and because there could be issues like what Fujimoto was talking about, that maybe the flow characteristics have changed after treatment, and now we're seeing it. But I just wonder, was the PED always reduced in size when you could spot it, or were there cases where the PED was the same height, but the CNV materialized?
yeah, thank you for your question. I was wondering about that too. And in some cases, the PED height didn't decrease significantly, but the lamellar structure at the back surface of the RPE became visualized even on the B scan, as well as on the OCT-A. So
I think those cases are the most instructive and important then. If you have the same segmentation and the same PED height, and it appeared, that does suggest that there's something about the flow characteristics of the lesion that evolved over time that allowed you to see it. I think that's very powerful.
One question I have to you, Vas, is the case I showed earlier this morning about the polypoidal CNV under the very large RPE detachment. I was able to visualize that. With a normal segmentation, you didn't see anything, you just saw noise. So I resegmented it manually to be very, very slightly below the bottom hyperreflective part of the RPE. And when I did that, I got a much better visualization of the CNV. Do you think that we need to come to some kind of consensus when it comes to trying to segment lesions in RPE of where to put the segmentation lines? Because right now the segmentation lines don't work for RPE detachments.
So my concept is that there probably is not a one-size-fits-all. So I think you're going to have to do, I think actually the approach is when you have a PED, you'll have to have, I would propose you do multiple thin slab segmentations, and then you can recombine them later to try to see if you can visualize it. I mean, maybe Kyoko no Matsuki can speak to it, but I know, for example, in some myopic CNV patients, actually the best place to see CNV is actually like in the sclera. Actually, you can visualize it better there. So the reality is that, you know, there's not going to, I don't think there's a one-size-fits-all. I don't think we can standardize it that way, but there could be a standard. You have to look through a stack, doing it this way, to be confident that you actually have done everything possible to visualize the CNV. That's my own opinion.
One of the problems that is encountered when you look at optic disc drusen, as Anne-Sophie Lindberg described, and if you look at thick occult new vessels, as Sarah described, is that flowing blood casts a dense shadow. And especially if the direction of the blood vessels is not at a right angle to the incoming detection light, then the orientation of the erythrocytes will throw the light away from the detector, and that casts an even more dense shadow. And to compensate for that would probably require a readjustment of the auto gain adjustment that happens during the recording, so that it gives priority to deeper signals rather than trying to optimize the inner layers of the retina. Is there a way that this can be done?
I'm actually playing around with doing that and using the structural data to weight the OCT-A data, also for projection artifact removal. So you have a weighted projection artifact removal, but I think you have a very good point. So you need to use the information you have in the structural data to interpret the data you have in the OCT-A, and I think that we're going to get a lot better information that way.
That's true. Okay, if there are no other questions, just before I close this session, I just want to, there was one person I forgot to thank because I saw my timer clicking down, and I thought I better start my talk, but it's Catherine Chisholm, who's really behind the scenes really made this meeting happen. Logistics are really complicated, so I think she deserves a round of applause.